Welcome to the deep dive. So picture this. It's 3 in the morning, the emergency department is quiet just for a moment, and then the paramedics roll in, a patient just doubled over, gripping their abdomen. The pain came on fast, and it is severe.
Oh, yeah. That sound. It really only means one thing in the hospital. We're dealing with the acute abdomen.
The highest stakes.
It is, yeah. It's the most time-sensitive category in acute care, you know? We're talking about a rapid onset of pain that means, look, without an immediate diagnosis and maybe surgery, this patient is in deep, deep trouble.
And the scale of this is it's staggering. Our sources say this accounts for up to 10% of all ED visits in a year. That's a huge number of people in immediate crisis.
It's massive. And our mission today is really to cut through that complexity, to understand the language of urgency.
Exactly. Because when a surgeon gets that call, they aren't reading a textbook.
No, not at all. They're looking at images. And the reliance on CT scans has just skyrocketed. At the institution we looked at, CT scans of the abdomen and pelvis make up nearly a third, 29% of all the CT exams they do in the ED.
Wow.
So that scan, it's the key. It's the translator between the patient's symptoms and the surgical plan.
So we're essentially learning to read this high-stakes internal map. And to organize this deep dive, we've built our conversation around the 5 major categories of complications that mean emergent surgery is needed.
Right. If you spot these signs, the clock starts ticking instantly.
And they are obstruction, ischemia, perforation, infection, and bleeding. Okay, let's start with obstruction, a physical blockage in the system. You have the chart, the patient is bloated, vomiting, and the scan is up on the screen.
Right. And for a small bowel obstruction, an SBO, the first thing we think of, especially in North America, is adhesions.
Scars from old surgeries, right?
Exactly, internal scar tissue. And if those adhesions are causing just a simple SBO, we often have a little window for conservative therapy.
Okay, tell us about that strategy, because avoiding surgery, if you can, sounds well and brilliant.
It's always the hope. We put the bowel at rest, and then we try what's called a water-soluble contrast challenge.
A dye, basically.
Yeah, a harmless dye you can see on an X-ray. If that contrast gets past the point of obstruction in a few hours, it suggests the blockage is only partial, or maybe it's resolving on its own.
And the patient could go home.
They could. They might avoid the operating room entirely, which is a huge win.
That's the best-case scenario. But what's the one finding that changes the whole game? The thing that makes you go from, let's wait and see, to rushing that patient to the OR.
That's the one. That's a notorious closed-loop obstruction, or CLO.
And that's the point of no return.
It is. Detecting a closed-loop obstruction always means emergent surgery. The key is that the bowel's blocked at 2 different points. Think of a hose tied off in 2 spots.
But isn't every obstruction dangerous? Why is the CLO in particular such a rapid-fire catastrophe?
Because of strangulation. It's not just a traffic jam for, food and fluid. It's a strangulation of the blood supply. The first thing to go is the low-pressure venous flow out. The high-pressure arteries might keep pumping blood in for a while, but nothing is getting out.
So it's just swelling up.
Massively.
Yeah.
You get congestion, edema, and then very quickly, tissue death ischemia, which progresses to infarction and necrosis. That piece of bowel is dying.
And if you wait, it perforates.
It will perforate and spill its contents. So yeah, seeing that little U or CE shape on the scan, showing those 2 blockage points, that's it. Game over.
It's incredible how a shape on a screen can mean so much.
Absolutely. Now, to contrast that urgency, we have to mention the heavy reality of palliative cases. If the SBO is from advanced peritoneal carcinomatosis, so widespread cancer filling the abdomen with blockages everywhere, the surgeon is likely going to defer any aggressive surgery.
Because it wouldn't cure the underlying disease.
Right. The goal shifts to comfort. Usually that means palliative decompression with a tube and then transitioning the patient to hospice care. A very different path.
A powerful contrast from life-saving repair to compassionate palliation, all decided by the cause you see on that scan. Okay, let's move down to the large bowel obstruction, the LBO. What's the usual suspect there?
For LBO, malignancy is the most common culprit. So the surgeon is actively looking for secondary signs, like swollen lymph nodes, metastases, anything that points to a tumor.
And this brings us to one of the most fundamental risks in surgery, the cecal danger. Why is the cecum, the first part of the large intestine, so prone to perforating?
It all comes down to a critical concept in physics, actually, the law of Laplace.
The law of Laplace. Okay, break that down for us.
Well, in a really simplified way, it just says that wall tension is proportional to the radius, and the cecum, well, it just happens to have the widest radius of the entire colon.
So when pressure builds up behind a blockage, the cecum is just It's mathematically doomed.
It's precisely that. Its wider radius means it accumulates the highest wall tension the fastest. That leads to thinning, and then bang, rupture. We saw a case where an LBO from severe diverticulitis, the cecum had dilated to over 12 centimeters.
That's huge.
Massive. And it had a dusky look, which means impending ischemia. You have to remove that time bomb now.
That structural threat, a failing wall, is a perfect lead-in to our next two categories. Ischemia, the failure of blood flow, and perforation, the actual breach. Mesenteric ischemia. That sounds like a race against time.
It's the ultimate surgical emergency.
Yeah.
We separate it into arterial ischemia, which is often a clot that traveled from the heart, maybe.
Okay.
And venous ischemia, which is more of a local thrombosis, usually from severe congestion and swelling.
So what are the imaging signs that tell you this piece of bowel isn't just sick, it's actually dying?
With acute arterial ischemia, the bowel wall becomes hypoenhancing. It looks dark on the scan because no contrast, and so no blood is getting to it. It's dead tissue.
And if it goes on for too long?
The bowel just goes slack. Peristalsis stops. And it develops this really unnerving paper-thin appearance.
Wow. But the signs of venous ischemia, especially from a superior mesenteric vein thrombosis, they sound even more insidious.
They are. With venous thrombosis, you get congestion and edema, so the bowel wall gets much thicker, much more swollen. The real tipping point, though, the thing we're all looking for, is the presence of gas.
Gas. Okay, let's pause on that. Why is seeing gas so terrifying here?
Because it tells you the story of a bacterial invasion. That gas isn't just trapped air. It's gas produced by bacteria that are now eating through the dead tissue.
So the wall integrity has failed.
Completely. That's why the radiologist's report becomes a checklist. Patency of vessels, any blockages, presence of gas. And critically, are any other organs involved, like the liver or spleen?
Why does that matter?
Because if they are, we know the source is an embolus, probably from the heart. And that changes the entire management plan moving forward.
That's a huge insight. So the imaging doesn't just show the damage, it points to the cause. Okay, let's talk perforation, starting with diverticulitis. It's so common, but where is the line between conservative care and, well, catastrophe?
Uncomplicated diverticulitis is just localized inflammation, some fat stranding. We treat that conservatively. The line is crossed the moment there's a perforation or a fluid collection you can drain. That's complicated diverticulitis.
And the high-risk classification for that is pretty graphic, isn't it?
It absolutely is. We use the modified Hinchey classification. When you get to stage 3, that's purulent peritonitis pus has spilled into the abdomen. Stage 4 is succulent peritonitis.
Fecal material?
Fecal material is free in the abdominal cavity. That's a catastrophic infection. It needs an immediate surgical washout, probably a colostomy.
And there's a great clinical note that even after a patient recovers from a first uncomplicated episode, there's a follow-up.
Correct. The recommendation is usually a colonoscopy 6 to 8 weeks later, to make sure that the inflammation we saw wasn't actually hiding an underlying malignancy that was just mimicking diverticulitis.
Wow. Okay, moving to cholecystitis, gallbladder inflammation. This often starts with an ultrasound. A US. What's the diagnostic quartet the surgeon is looking for in that report?
We're looking for 4 key things. Gallstones, obvious wall thickening. Anything over 3 millimeters is suspicious fluid around the gallbladder, which we call pericholecystic fluid, and a positive sonographic Murphy sign.
Which means it hurts when they press on it with the probe.
Exactly. But here's where the urgency can escalate dramatically. The gangrenous threat. Gangrenous cholecystitis is wall ischemia. The gallbladder itself is dying. It gets thin. The membrane starts sloughing off. Now, if the patient is stable, we might schedule surgery for the next day.
But if they're not?
If they're unstable, or that wall looks really compromised, the team might choose immediate decompression instead.
Decompression? You mean putting tube in?
Yes, a cholecystostomy tube. It's a temporary fix. It drains the infected fluid, relieves the pressure, and lets the patient stabilize before they have to go through a much bigger definitive surgery later on.
And the imaging decides that whole path.
The imaging assessment of that wall is everything.
We've saved the most immediate life or death scenarios for last. Bleeding and aggressive infection. Let's start with hemorrhage. The ruptured abdominal aortic aneurysm, a AAA.
This is a devastating diagnosis. The mortality stakes are just staggering. Half of these patients never even make it to the hospital.
And the overall mortality?
It's near 90%. Delay is death. It's that simple.
So a patient comes in with that classic abdominal or back pain, low blood pressure, they're rushed to CT. What's the smoking gun, the undeniable sign of rupture?
Active extravasation of contrast. You can literally see the dye leaking out of the aorta on the scan.
Wow.
That, plus a retroperitoneal hematoma blood pooling behind the abdominal lining, that's confirmation. We also look for something called the draped aorta sign.
That sounds dramatic. What is that?
It means the back wall of the aorta isn't distinct anymore. It's blurred and looks like it's draped over the spine. It's a very specific clue that tells us the aneurysm is leaking, even if we can't see the active bleed just yet.
And the surgeon doesn't just need to know it's ruptured. They need a full checklist right then and there to decide how to fix it.
Precisely. Open surgery or an endovascular repair, an endograft. The report has to specify the aneurysm's size and shape, its relationship to the iliac arteries, and most critically, its relationship to the renal arteries, the vessels going to the kidneys.
Why is the kidney-artery relationship so important? Why does that dictate the whole strategy?
Because it determines the entire approach. If the aneurysm is infrarenal, so below the renal arteries, we can often do a less invasive endograft, basically snaking a stent up from the groin.
Okay.
But if it's juxta or suprarenal involving or above those arteries, the procedure becomes vastly more complex. Often it means a massive open surgery clamping the aorta above the rupture. The scan is the preoperative blueprint.
Finally, our fifth threat. Aggressive infection, specifically necrotizing soft tissue infection, or NSTI. This sounds horrific.
It's truly one of the most frightening diagnoses we make. NSTI is a polymicrobial, gas-forming, aggressive infection. The mortality rate is well over 20%. It can start in the perineum, we call that fournia gangrene, and just spread relentlessly, eating its way into the abdominal wall.
And the imaging clue, again, is gas, but in a totally horrifying context.
Yes, the key finding is soft tissue gas, pockets of air in the muscle and the fat layers. And this gas tracks across fascial planes. It transverses the rectus sheath.
Spreading
Everywhere. And identifying NSTI mandates immediate aggressive surgical debridement. You have to cut away the tissue until you find healthy bleeding edges. We've seen cases where, despite doing everything right and fast, the systemic infection was just too far gone. Sepsis and death days later. That's how ruthless this is.
This deep dive has really laid bare the level of detail needed to navigate the acute abdomen. We've hit the 5 major emergent categories: obstruction, ischemia, perforation, infection, and bleeding, and how that diagnostic imaging is the absolute critical bridge.
It really is. It highlights how these huge management decisions, from a conservative contrast challenge for an SBO all the way to complex endograft planning for a ruptured AAA, it all hinges on the subtle appearance of the abdomen on a scan.
The difference between a minor wall thickening and an actual impending structural failure
Is literally the difference between life and death.
I found a distinction in the sources that just exemplifies this nuance perfectly. We know appendiceal wall thickening can be common reactive inflammation, standard care.
But that exact same thickening might also be a low-grade mucinous neoplasm.
A type of tumor.
Exactly. And while they might look similar, the neoplasm requires very careful, non-emergent surgical removal to prevent mucus from spilling into the abdomen, which can cause a terrible condition called pseudomyxoma peritene. The whole strategy changes based on that subtle difference.
Which leaves us with a provocative thought for you, the learner. This entire field relies on clinicians differentiating common inflammation from the very moment a lethal complication develops. So if subtle findings like pericholecystic fluid or a tiny shadow of mesenteric venous gas are the difference between waiting until tomorrow and operating right now, what other critical fine-line distinctions in modern medicine carry that same immediate life or death weight? We'll leave you to think about that until our next deep dive.